Yesterday was the 23rd September 2025. It was a Tuesday in New York. Today is 24th September 2025. It's a Wednesday in New York. And tomorrow is the 25th September 2025. And it's not an ordinary Thursday in New York because we have the fourth high-level meeting on NCDs and mental health taking place at the UN headquarters here in New York. So that is an important day for the global health community, for us in the global NCD community, but most of all for people who are at risk of or suffer from non-communicable diseases and mental health conditions. We have worked for a long time to prepare for tomorrow. A lot of things, a lot of progress has been seen since the third high-level meeting on NCDs back in 2018. We have seen that the agenda of primary care has grown, and we've seen the agenda of people-centered care has grown. The agenda of integration has grown. So while tomorrow is a high-level meeting on NCDs and mental health, most of all, it is a meeting around health for all. And that is why we're here today, because over the past time, the World Diabetes Foundation, together with our co-organizers, FIND, Resolve to Save Lives, UNAIDS, United for Global Mental Health, and the NCD Alliance have worked together to host this event today, to show that we can unite across different health areas around a common agenda. We are extremely grateful for the presence of the Denmark government, Minister Løde, Minister of Interior and Health. We are very grateful for your support to the event. We are equally very grateful to the government of the United Republic of Tanzania, Minister Sharif. Tunashukuru sana. Karibu sana. Of course, with government recognition of our event, we can see that there is political support to an agenda around integrated care and equity. We will today discuss different aspects of primary care, people-centered care and integration. We will hear from global stakeholders. We will hear from people with lived experience of various conditions. We will hear from ministries of health, technical leaders implementing programs on integrated care. But before that, we will have a high-level opening segment with opening remarks. And before that, we will have a statement of a person with lived experience. So if we could have the video recording of Miss Carol Nawina, please.
Thank you for having me here to share my story. I live with diabetes, HIV, and I'm also a TB and cancer survivor. When I got sick in the early 2000s, my symptoms were dismissed. Even when my body was screaming that something was wrong, it took months before I was finally tested. By then, I had fully blown AIDS, TB, and cancer. But here's the truth. The real damage wasn't just from the infections, it was from the delay, the lack of timely accessible diagnostics. I survived, but just barely. I consider myself lucky because many do not. I still carry the memory of that fear, that helplessness, and that endless wait. And yet, each condition I live with, I have to go to a different clinic, stand in a different queue, and carry the burden of cost and stigma and exhaustion. Every decision about my care depends on a test, whether a viral load test, a sputum test, or blood sugar reading. Sometimes these tests are not available when I need them the most. Imagine what it would mean if one machine in my local clinic could give me all those answers in one visit. That would save me hours, money, and dignity. Don't cut me into several pieces to suit the fragmented health system. I'm one person. Treat me as such. Integration is not just about systems, it's about survival. And it does not end at the clinic, it happens in the community. When care is close to home, when testing becomes part of everyday life, stigma begins to fade. Community is where equity and dignity are lived. My story had a second chance, but health should not depend on chance. It should depend on timely access and the political will to deliver it. So, as this session begins, I ask you to remember behind every policy and model are people, people like me. We are not just patients, we are mothers, fathers, workers, and friends, people with hopes and dreams. As per our motto, nothing about us without us. Let us turn today's discussion into action that brings real change to people's lives. I thank you.
This was Carol Navina from Zambia. Don't cut me into pieces. Don't pretend policies will automatically be adapted. So that's why we are here, to discuss the advancement of integrated care. We will now move to the high-level opening segment, and I have the honor of inviting to the stage Minister Sophie Løhde, Minister of the Interior and Health of the Government of Denmark, please.
Excellencies, colleagues, ladies and gentlemen, I'm honored to speak at this important event about equity and integration in health. And firstly, Bent, let me thank our host for convening us here today to discuss one of the defining health challenges of our time, non-communicable diseases and mental health condition. And I must add, I don't think it's a regular Wednesday in New York today. Why? Because we are all gathered here today. The reality is clear. NCDs remain the leading cause of death worldwide, and the challenges will continue to grow if we do not act. Imagine health systems like safety nets. If they are strong, they will carry out people safely through life, through good times and bad times. But if the safety net has weak spots, if access to prevention and treatment is missing or unequal, then people will fall through. In Denmark, we are right now working to reform the safety net and making it even stronger. As health needs change, health systems must adapt, not only to keep up, but to further improve health outcomes. In Denmark, we are reshaping our health system to ensure that patients can access and navigate the system much easier. I'm referring to the most comprehensive reform of Danish healthcare in decades, a reform aimed at bringing healthcare closer to citizens and their daily lives, a reform that is patient-centered, a reform that seeks to enhance coherence and improve patient pathways. The reform has many aspects, and I will not go into the full list of initiatives, otherwise I might be the only person speaking here today. But the core of our reform is a strong and much more accessible healthcare sector. This also involves new standards for care to patients suffering from NCDs. We call them chronic care packages. These are new standards, offer a clear, coordinated journey through the health system for patients with NCDs. And imagine a patient who has recently been diagnosed with diabetes. This person will receive a coherent and personalized treatment plan. Or a COPD patient who needs seamless care from diagnosis to treatment to rehabilitation. Patients should have the right to comprehensive health services tailored to individual needs. And that is what these new standards will provide. With the health reform, we aim to reduce inequality in health. This means readjusting and redirecting resources. We need to provide even better care to patients in underserviced areas and to vulnerable groups in greater need of individual support and care. We will also increase the number of doctors in primary care with 40%. and access a shortage of doctors outside the larger cities. We intend to provide more care outside the hospitals, in local clinics, in people's home, or even on their phones. In this way, we can reach more patients with the care they need and make better use of our resources in our healthcare system, because a strong primary sector is important for the patient and it is cost effective. It improves the efficiency and long-term sustainability of health systems. That is what we aim for in Denmark. We are also right now implementing a 10-year plan to strengthen psychiatry and mental health. One of our main goals is to reduce the time from initial symptoms to treatment for especially our young people, children and young people. We will implement an initiative, for example, where every municipality offers easily accessible treatment for children and young people. And I know that countries around the world are struggling with similar challenges. And in closing, I want to make this clear. We definitely do not have all the answers. Denmark is a small, open economy, but we recognize that international cooperation is crucial. To be prepared for the future, we need to work together across sectors, across borders. And let us work together to make strong safety nets all over the world. Safety nets that will prevent people from falling, safety nets that ensure lives where chronic conditions can be managed and quality of life can be improved. Thank you very much.
Thank you very much, Minister Løde. This was exactly what we hoped. You would come and bring the commitment to the agenda, to Denmark's perspectives, you can say, moving forward, but with a global relevance in a meeting today. And we can agree it's not a regular Wednesday. I'm very honored now to invite the Honorable Minister of Labour and Economy of the United Republic of Tanzania. Honorable Minister Sharif, please, your opening remarks.
Your Excellency Sophie, Minister of Health of the Kingdom of Denmark, distinguished delegates, colleagues, ladies and gentlemen, a very good morning to you. It's a privilege for the United Republic of Tanzania to co-host this important event alongside the Kingdom of Denmark at the helm of this high-level meeting on the prevention of and control of non-communicable diseases and the promotion of mental health and well-being. The theme of this meeting, equity and integration, reshaping health systems through people-centered primary care, is not merely an aspiration of Tanzania, and indeed for many low and middle-income countries, it's an urgent imperative. The rising tide of NCDs threatens to erode health and development gains unless we act decisively together. In Tanzania, non-communicable diseases and mental health conditions account for 33% of all death and 40% of disability-adjusted life years. To respond effectively, our National NCD Strategic Plan 2021-2026 requires an estimated United States $3.2 billion. Despite constraints, we have expanded domestic health financing fivefold since 2007, with government contribution now reaching 68% of the national health budget. We are strengthening our health system by integrating diabetes and hypertension services with HIV, maternal health, sickle cell disease, and mental health. This holistic, people-centered model enhances clinical decision-making, patient engagement, and long-term outcomes. We have established diabetes clinics nationwide where insulin is provided free of charge to children and youth under 21 years old. We have scaled up training, routine screening, and the supply of essential medicines and technologies guided by our national clinical guidelines for NCDs, which ensure continuity of care even during emergencies. These achievements have been possible through partnerships. I wish to acknowledge the World Diabetes Foundation, the Tanzania Diabetes Association, Novartis, the Melian Foundation, and many others. Their contribution have supported training, improved infrastructure, strengthened primary facility, and expanded screening and referral systems, making diagnosis and treatment more timely and accessible. On mental health, Tanzania is integrating services into primary care, maternal health, and HIV programs. We have launched a digital mental health platform, including a 24/7 toll-free helpline, which reaches young people and vulnerable groups. We are also using nationwide campaigns such as Mtu ni Afya, meaning a person is health, and Usijisahau Jali Afya Yako, meaning do not forget yourself, care for your health, to promote healthy lifestyles and reduce stigma. These are complemented by our annual NCD Prevention and Control Weeks, which mobilize communities across the country. At the governance level, reforms such as direct health facility financing and universal health insurance schemes are reinforcing accountability, sustainability, and multi-sectoral collaboration, supported by both the public and private sectors. Yet, challenges remain. High numbers of undiagnosed cases, especially in rural and remote areas, insufficient financing at both domestic resources and external support remain inadequate and are unpredictable. Shortages of skilled human resources, especially in oncology, endocrinology, psychiatry, and diagnostics. Unequal access to medicine diagnostics and technologies across the health system. Persistent stigma around mental health and insufficient integration of services at the primary care level. And weak data systems with the need for more robust registries, surveillance, and real-time monitoring. These obstacles slow our progress toward fully integrated, equity-driven primary health care. Excellencies, Tanzania believes that no country can win this battle alone. We therefore call for global action in the following areas. 1, scaling up sustainable and predictable financing for NCDs and mental health, both domestic allocations and international support, structured to be long-term, not fragmented. 2, strengthening primary health care at the front line, ensuring NCD and mental health services are integrated, continuous, and people-centered. 3, boosting partnership and knowledge exchange, learning from initiatives such as those supported by the World Diabetes Foundation, and investing in research and innovation that can guide policy and scale successful models. 4, enhancing data and accountability, including strong surveillance systems and transparent reporting of progress. And number 5, addressing social determinants of health through multi-sectoral policy in food systems, urban planning, education, taxation, and regulation to reduce risk factors such as tobacco use, harmful alcohol consumption, unhealthy diets, and physical inactivity. In my conclusion, distinguished delegates, behind every statistic is a person. a mother whose life is cut short by complications of hypertension, a child whose future depends on access to insulin, a young person whose potential is diminished by untreated depression, and families left behind by preventable death. For Tanzania, equity and integration are not abstract ideals. They are the foundation of resilient, sustainable health systems. With global solidarity, adequate resources, and committed partnership, we can reshape health systems so that every person, everywhere, can access the care they need and deserve. Tanzania stands ready to share experiences, learn from others, and collaborate globally. We call upon development partners, financial institutions, philanthropies, and the private sector to support Tanzania and Africa in advancing NCD and mental health prevention and care, and in scaling up universal health insurance. Together, we can save millions of lives and build resilient, people-centered health systems. Thank you very much for listening to me. Asante sana.
Thank you so much, Minister Sharif, and I'll correct myself, Minister of Labor, Economy and Investment. So obviously today we appeal to the government of the United Republic of Tanzania to continue the investments in primary health care. Thank you so much. We have seen the progress achieved. We are many stakeholders who have been supporting for many years. And in fact, one of the big agendas that has also grown since the third high-level meeting in 2018 until today is the multi-sectoral approach to NCD prevention and control. And today we have a Minister of the Interior and Health and a Minister of Labor, the Economy and Investment. So we already see the political commitment to the multi-sectoral ownership of the agenda. We will thank you again, Minister, for coming today. The final speaker in our opening segment is, if we could have the next slide, please, is Leanne Riley from the World Health Organization, heading the surveillance and monitoring area of the NCD and mental health department of the World Health Organization. There would be no global health response without the World Health Organization. And we need the WHO to unite the agendas, to advance technical and normative work, and mobilize resources and advocacy. So Leanne, please, the word is yours.
Thank you, Bent. Thank you for those kind words. Good morning, everybody, excellencies, colleagues, partners, and friends. It's an absolute honor to join you today at this critical moment in our collective journey. It's indeed no ordinary Wednesday, and tomorrow will be no ordinary Thursday. We are on the eve of the 4th UN high-level meeting on NCDs and mental health, and I'm, like perhaps others in the room, this will be my 4th meeting, possibly my last, let's see. So a huge thanks to our partners, including the World Diabetes Foundation, FIND, UNAIDS, United for Global Mental Health, the NCD Alliance, and Resolve to Save Lives for hosting this fantastic event. We're here today to reaffirm a truth that has long guided public health for nearly half a century. Primary health care is the foundation of resilient, equitable, and sustainable health systems. If we're serious about achieving universal health coverage and delivering on the Sustainable Development Goals, including the one associated with NCDs and mental health, we absolutely need to focus our efforts on people and not diseases. And we need to build health systems around their needs, their realities, and our communities. For decades, global health investment has been driven by vertical, disease-specific programs. While these efforts have saved lives, they've also caused fragmentation, duplication, and gaps, and we've heard about some of those today. But today we actually know better. The data, the evidence, and of course the lived experience of millions tells us that integration is not only more efficient, it's essential. From HIV and tuberculosis to diabetes and hypertension and to mental health, these conditions do not occur in isolation, and neither should our response. We must acknowledge as well that mental health has long been under-prioritized and neglected for far too long. Mental health conditions are both risk factors for and consequences of other health challenges, and they often prevent people from accessing the care that they desperately need. So integrating mental health into primary health care is also no longer optional, it's urgent. This means that we need to expand access to psychosocial and psychological support at the primary care level. And it means investing in community-based models and shifting away from institutionalized care. It also means centering the voices of people with lived experience into everything we do. We cannot speak of integration without addressing the glaring diagnostic gap. Today, nearly half of the world's population and over 80% in low and middle income countries lack access to basic diagnostic services at the primary care level. And honestly, today, this is just unacceptable. Without diagnosis, conditions are detected late, and then people are treated poorly or not at all. And without medicines, the promise of integrated care remains just that, an empty promise. We must expand to point-of-care tools, essential medicines, and digital platforms that support diagnosis, referral, and continuity of care. And we must make those things affordable, available, and equitably distributed. Let's be honest, integration will not happen on our good intentions alone. We need a shift in how we finance health systems from fragmented, siloed funding streams to aligned, pooled investments that support people-centered care. And that does mean we need a shift in domestic resource mobilization, so very happy to hear about these efforts in Tanzania. We also, though, need to make much smarter use of external financing to support national planning, catalyze systems reforms, and reduce the out-of-pocket expenses and costs for patients. At WHO, we stand proud to support countries as they reshape their primary healthcare systems, and we provide normative guidance, practical tools, and implementation support. We collaborate with our partners at UNAIDS, at Africa CDC, at the Global Fund, the World Bank, and others to promote this alignment and action. Our message is clear. Integrated, people-centered primary healthcare is not a vision for tomorrow, it's a necessity for today. Colleagues, the political declaration to be approved tomorrow reaffirms our shared direction. The evidence is in, the tools exist, and now we see these partnerships growing. Now we must go further, and we must operationalize this vision. We must fund it, and we must scale it. Let's make this the decade where integration becomes the norm and not the exception, where equity is not just a principle, but a practice, and where people-centered care becomes the reality for every community everywhere. I thank you.
Thank you very much, Leanne, and we are all grateful and in need of the continued advancement from the WHO around this agenda. So thank you very much. We will have a 1-minute break because we are aware of the minister's delegation might have to leave very soon. We'll have a 1-minute break for a photo photography session. If you allow Minister Løde and Minister Sharif, please come to the podium. We will have a photo. Leanne, please. And one delegate from the 6 co-organizers, please. Katie and James will have a photo. We are hereby closing the opening section. Please take your seats. We are waiting. We will start the next main program segment, which is panel 1, which we have entitled Setting the Stage, Integrated Primary Health Care as Pathway Towards Universal Health Coverage. Before we start the main program, we will just announce that there's a Wi-Fi here called Marriott Bonvoy Conference, and the password is integration. And there is a repository. There is a repository through the QR code that you can see on the flip side of the program. That will take you to a website where we have uploaded a range of materials, guidelines, scientific papers about integration, primary care, and equity, including a very new guideline published by the WHO around the integration of HIV with diabetes, hypertension, and mental health services. But we will start the main program, panel 1, and I will now hand over the word to my co-moderator, Kathy Haldane from FIND, NCD Director. Please, Kathy, over to you.
Thanks, Bent. Hello, everybody. It's an absolute pleasure to be here, and what a powerful Wednesday it is. What incredible opening we've already had with a high-level delegation, and it's a powerful start to this agenda. We gather here at a pivotal moment. The recent political declaration on NCDs and mental health has sent a strong message that strengthening primary care and advancing integrated approaches is no longer optional, but essential. And our discussions today could not be more timely nor more necessary. So we're going to be starting with our first panel, Setting the Stage, Integrated Primary Healthcare as the Pathway Towards Universal Healthcare Coverage. I'm going to be introducing each of the speakers, and when I do that, I want to ask each speaker to please come and take a seat up front. Our first speaker is Mr. Antoine Saint-Denis, the Director for International Affairs, Ministry for Health in France. Welcome. Good morning. it's a pleasure to introduce Mohammed Abdul Aziz, the head of the Division for Disease Control and Prevention at Africa CDC. Welcome. Representing the Global Coalition of Countries on Primary Healthcare, it's a pleasure to introduce Anar Tumak Hambetova. And representing Resolve to Save Lives, Bulanle Banigwe, Global Technical Director, Hypertension Control. Welcome. To provide opening remarks to this panel, it's a pleasure to introduce Anjali Akragar, the Deputy Executive Director for the Program Branch and Assistant Secretary General of the United Nations from UNAIDS. Please, thank you. We look forward to your remarks.
Good morning. What a fantastic group of people. It really is a special Wednesday morning to see so many people engaged and with us. Let me first start by thanking this incredible high-level group that was just with us, particularly the government of Tanzania and the government of Denmark. I really also want to thank all the other dignitaries, friends, colleagues in the room from all sectors that are here today. I wanted to just provide a few opening comments before we hear the really incredible insights from the panelists here. Today, we're coming together more closely than ever before across sectors, across disease-specific programs for three critical reasons. The first, as we heard from the very first video from Carol, people are not in parts. Countries, communities, partners all over the world are increasingly recognizing the truth that people are holistic human beings and that people have multiple health needs. Those needs are not just HIV-specific needs, malaria needs, hypertension, needs for hypertension. People do not come in parts. The second piece that I wanted to talk about is that silos are not sustainable. I come from 25 years in the HIV response, together with 11 different UN agencies, including WHO, that we just heard from. What we have learned in the HIV response is that at an emergency state, it was absolutely critical that we come together and really focus deliberately on a very specific disease. And we've seen incredible results over time. But what we know is that these vertical programs that have achieved significant results are not sustainable. We have to move beyond the silos. That's the only way that programs, services can be sustained. So again, silos are not sustainable, and we're learning those hard truths through the HIV response, and we're tackling that to make sure that we can integrate and work with partners to integrate HIV services into country and community systems into the future. The third point that I wanted to raise is related to the multi-sectoral approach. Multi-sectoralism is a must. We heard that both from the two ministers of health and then the Minister of Labor, Finance, and Investment that we heard from both Denmark and Tanzania as well. Primary health care will not work without a multi-sectoral approach. That approach is built on collaboration across sectors, across health, finance, justice, community, all sectors coming together and being engaged. That's how societal and structural determinants of health are addressed through a multi-sectoral approach. That's why nearly 30 years ago, when UNAIDS was born here in New York, it was across 11 different UN agencies that represent different sectors to tackle a common vision. At that time, it was HIV and AIDS. We know now that that lesson of multi-sectoral approaches is absolutely critical in what we have to do as we look at NCDs and we move into the future. We, from the HIV response, are opening and changing and transforming as we speak. We're on the cusp of creating a new strategy for AIDS. One of the singular most important priorities of that strategy is around integrating into primary health care services, broader health systems, country systems, and community systems, and really working across people-centered care. So this is where we're all headed. The final thing I'll just say is just what was noted before by my colleague from WHO, that integration must become the norm, not the exception. This is the moment, not yesterday, not tomorrow, today. This is the moment that we all must move together toward this shared vision of integration, not as an option, but as a necessity. So I just want to thank you all. Really excited to kick off the morning together with you, and excited about the panel that is about to share insights. Thanks again.
Thank you very much, Angeline. I think you've really set the scene so well for our panel. And really what I think stood out from what you were saying is silos are not sustainable. That is really key for going forward. We're looking forward to hearing from our panelists. So I'm going to hand over to my co-moderator for the introduction.
Thank you very much, Kathy. And we have a very rich program ahead of us for the rest of the event. So we will go straight to the next intervention, which is a very important intervention from the representative of the Republic of Kazakhstan, Ms. Anar, please. And you represent the coalition of member states for primary health care. Please, the podium is yours.
So, first of all, let me allow, on behalf of Ministry of Health, Republic of Kazakhstan, to represent our vision to the primary health care. So allow me to welcome all participants of this important event. The President of the Republic of Kazakhstan, His Excellency Kassym-Jomart Tokayev, initiated the establishment of the Global Coalition on Primary Health Care, recognizing that PHC is a key to building resilient and sustainable health systems capable of meeting people's needs and diverse settings. Today, we would like to highlight the importance of political economy in making key policy decisions required to ensure the effectiveness of PHC. These important aspects will be discussed during the session. Undoubtedly, we must maintain commitment to the first, strong political will and leadership in primary health care, effective governance, adequate financing, and rational allocation of resources to PHC. Active engagement of communities and stakeholders in primary healthcare development. Kazakhstan and WHO are working closely together to establish the Secretariat of the Global Coalition of Primary Healthcare. The coalition serves as a political platform to accelerate the reorientation of health system towards primary health care. It promotes policy innovation, experience sharing, and strengthening of PHC's central role in achieving universal health coverage. It's a great honor to us to hold this event and support the coalition, and I would like to express my deep gratitude to the co-sponsors, Thailand, Hungary, Armenia, Bhutan, WHO, UNFPA, UNICEF, and the NSD Alliance. The purpose of such events to strengthen global political commitments and mobilize leadership in PHC, as well as to ensure concrete actions within health system worldwide. The world cannot afford to view primary health care as a goal for the future. It must be strong today, as a shield against the future crisis, as a mechanism for ensuring equity, and as a reliable investment in human capital and social cohesion. Distinguished delegates, Kazakhstan remains firmly committed to strengthening cooperation with global partners and stands ready to promote primary health care as a foundation of health and well-being for all. Thank you for your attention.
Thank you very much, Ms. Anar. We know that in 1978 we had a declaration on primary health care, and in 2018, which was in Alma-Ata in Kazakhstan, in 2018 we had a second declaration on primary health care in Astana in Kazakhstan. We appreciate the leadership of the government of Kazakhstan to build a coalition of member states for strengthened political commitment. Hopefully more member states will join the coalition. Thank you again, and Kathy, please introduce the next speaker.
It's our pleasure to introduce Mr. Antoine Sandenas, Director for International Affairs, Ministry of Health. Welcome. Thank you.
Thank you very much. Good morning. Good morning, ladies and gentlemen. I'm delighted to be with you today. Let me begin by warmly thanking our host, the World Diabetes Foundation, Fine Diagnostics, UNAIDS, United for Global Mental Health, NCD Alliance, and Resolve to Save Lives. France is proud to join as a champion of primary healthcare and as an active member of the global coalition led by Kazakhstan, which I also salute. Tomorrow, the fourth high-level meeting on NCDs and mental health will take place, a key step in acknowledging both the urgency of non-communicable diseases and the importance of mental health. France welcomes the adoption of the political declaration. While we would have wished for more ambition and stronger language, it nonetheless marks progress. For the first time in a multilateral setting, mental health is fully recognized as an essential part of global health. This should compel us to move from words to action, more ambitious measures, stronger monitoring, and real implementation. In an increasingly fragmented world, we share a collective duty to safeguard hard-won health gains. Our vision must continue to rest on solidarity, equity, and cooperation, especially with low-income countries. That means not only strengthening global initiatives, but also encouraging sustainable national solutions as external aid shrinks. Countries must be able to mobilize their own resources around local priorities. Shaping the future of global health architecture must be inclusive, with close involvement of partner countries, civil society, and communities. A donor-driven top-down approach will not suffice. France is preparing its G7 presidency, which will coincide with the US G20 presidency. While priorities are still being defined, we will ensure that global health is given its proper place in the discussions on shared challenges. Allow me to return to today's topic, primary healthcare and equity. Universal health coverage cannot exist without strong, fair, resilient, people-centered primary care. This is a cornerstone of any health system and a central priority of France's global health strategy. We strongly support the integration of primary care approaches across diseases such as tuberculosis, HIV, diabetes, hypertension, and mental health. Promoting effective models of integrated care is not only a health necessity, it's an equity imperative. An equitable, timely access to affordable diagnostics is vital if we are to provide comprehensive, person-centered care. I particularly welcome the renewed attention to mental health, too often neglected. The burden is immense, worsened by the pandemic and ongoing crises. Integrating mental health into primary care means providing accessible, stigma-free support that truly meets people's needs. Today's discussion shows the value of these constructive dialogues and shared responsibilities. France is determined to keep supporting this momentum, working closely with WHO to make primary healthcare the foundation of a fairer, more resilient, and more human health system. Thank you.
Thank you. Thank you very much, Mr. Antoine.
We will go to the next speaker, and it's a pleasure for us to introduce Dr. Mohamed Abdulaziz, heading the Disease Control and Prevention Unit of the Africa CDC. Dr. Mohamed, please, the podium is yours.
Let me also follow the previous speakers by thanking the organizers of this very important and timely discussion on integrating primary health care as a pathway towards universal health coverage. Of course, we need the PHC if we are ever to have any form of full coverage of our population, especially speaking from the Africa perspective. And thank you, Angeli, for giving us the perspective of how the Vertica program started. We all know this. In Abuja in 2001, when we had the HIV upcoming fear that people were going to die, we needed an emergency approach to take care of that pandemic. And over the last 30 years, we've learned a lot. We've learned that at that time in Africa, we needed to focus our energy to ensure that we take care of that HIV pandemic that was on the continent. But we've also learned that in order for us to have any form of coverage, equity in our population, we need to change the approach to include inclusivity and access. And listening to all previous speakers, you know, access is a major problem. It's a major problem because we've verticalized many of our response, which look at diseases and not the person that is involved. So in this regard, what can we do to change this? If we need to also learn lessons from the Vertica programs. They were able to, focusing on one, get to the community. And this is what we're talking about. If we're going to do an integrated services, we have to do it in a way that we will be able to deliver good quality services right there in the community. And it has to be accessible to people in their community. And when we talk about access, it's not just about walking distance or distance to the hospital, also access to essential diagnostics, essential medication. Imagine a young child with epilepsy, and he can't have life-saving carbamazepine. He keeps having fits. He develops cerebral palsy. In mental health, we have over 95% in some of our countries that do not have access to services. And if you take in a village in Nigeria, for instance, somebody developing diabetes, maybe very close to the figure for mental health may not have access to what is required. So what do we need to do to change this narrative? We need to focus on areas that can give us immediate results. And for Africa, one of those areas is in the area of workforce. We need to ensure that we train the workforce in the PHC to be responsive not just to vertical programs. I know it's difficult because the vertical programs have pulled most of the community health workers and focused them. But we need to refocus, especially for non-communicable diseases, injuries, and mental health. Refocus the workforce in the community to be able to develop a way in which people will be able to have access, and through supervision from the primary and the secondary and the tertiary level. Health financing. In this area, we need to work with our government to domestic financing, like you say. What that means is that focusing a significant proportion of the product, the financing for health, to the PHC, and increasing the workforce, increasing the ability of the PHC to deliver the quality services that we're looking for. We talk about solarization, digitization, all of these innovations that we can use to get the PHC to a level that we could not do maybe just 10 years back. Again,
sorry, Dr. Mohammed, just one more minute, please.
Okay, thank you. Again, the multi-sectorial section, it's important because that is the area that will ensure people don't develop these diseases. They remain well, and the burden on the health facility, on the PHC, will be less. Thank you, Ben, for this. I had a lot. This is an area I'm very passionate about, but we will allow others to come in.
Thank you so much, Mohammed. Thank you so much. Thank you to the Africa CDC for the commitment to the integrated care approaches. We've seen also how the Africa CDC itself has grown since we had the third high-level meeting in 2018. Thank you, Mohammed. Please, Kathy, our final speaker for the panel.
Indeed, and we're really very thrilled to be able to introduce and welcome Balanle Baningwe, Global Technical Director at Resolve to Save Lives. Thank you.
Good morning, and thank you for inviting me. At Resolve to Save Lives, our mission is to accelerate action against the world's deadliest threats. And hypertension control in primary healthcare settings is one of our strategic priorities. To do this, we partner with government and in-country stakeholders to implement the WHO Heart Technical Package. And there are more than 40 million people on treatment across our partner countries. More than 95% of the partner facilities are primary health centers because uncomplicated hypertension is a primary care amenable condition. However, these programs manage people, not a diagnosis. So integration is at the heart of what we do. And I will share two examples. About 50% of the patients receiving treatment for hypertension in our partner programs also have diabetes. So treating their diabetes at the same clinic, by the same clinicians, at the same visit is a no-brainer. And that's what we support our partners to do. Many patients with hypertension and diabetes will also benefit from statins to control their blood lipids. This is now becoming a component of the standard of care in our partner programs by improving and updating their treatment protocols. Secondly, between 2019 and 2022, we funded and implemented HIV hypertension integration projects in 4 countries: India, Kenya, Nigeria, and Uganda. At the end of those pilots, all the HIV clinics had established universal BP measurement and hypertension treatment. And BP control ranged from 21% to 88%. Overall, what we learned is that it is possible to achieve high blood pressure control rates among people living with HIV within the HIV clinics while maintaining very high viral load suppression and retention rates. So, what are we learning? I will share 4 lessons. 1, simple protocols are critical, especially as we add on more services, because healthcare workers don't have the time or the bandwidth to review extensive guidelines documents during clinical consultations. Most of these protocols exist, and we should not be reinventing the wheel, but we should make sure that our guidance across conditions is streamlined. For example, in one country where we were supporting HIV hypertension integration, the Better Resourced HIV program required baseline lab tests before people were started on treatment for hypertension, while the NCD program for hypertension treatments in the general population did not. So there was a need to align that, and that is one of the ways that we go about integration. 2, user-centered, offline-first digital information systems that allow healthcare workers to enter data as they consult, and that completely replace paper would facilitate care. Integrated PHC would require us, technical partners and government, we need to dial back on the number of data elements that we require frontline healthcare workers to collect. Comprehensive electronic health records are great, but they remain aspirational. What we could think about is a suite of interoperable tools, such as the DHIS2 tracker app for different conditions. They could form like an EHR Lite that can help primary healthcare workers do their work efficiently. Third, team-based care is more critical than ever in assigning roles and in cross-training. Carefully integrating artificial intelligence into clinical teams can also help, especially with repetitive tasks like note-taking during consultation, maybe missed visit follow-up calls, lifestyle modification counseling, health education activities. Finally, there is a need, as everybody has said, to intentionally break down the silos between the Ministry of Health departments and among partners, to leverage what is working well from each vertical program, and to ensure that limited resources are used well. Yesterday, in collaboration with WHO, Bloomberg Philanthropies, Resolve to Save Lives, we launched the second Global Hypertension Report. And the report showed us that only 23% of the 1.4 billion people living with hypertension have their blood pressure under control. That report recommends integration of hypertension control into PHC system strengthening and UHC activities as one of the interventions to move forward with. And Resolve to Save Lives stands committed to continue to support countries to do that. Thank you.
Thank you very much, Bolanle. A great way to close the panel. Let's give a round of applause to the panel here. Kazakhstan, France, Africa CDC, UNH, and Resolve to Save Lives. Please take your seats again, and we will move directly to panel number 2. But in between the panels, we actually have another recorded statement. So if we could have the statement on, which is from Florence Riaco Anam, who is the global director of the network of people living with HIV, GNP+.
It is an honor to speak in this panel to provide the perspectives of people living with HIV and of my organization, the Global Network of People Living with HIV, GNP+. The number of older adults aged 50 and above living with HIV has significantly increased due to the highly effective antiretroviral therapy, which allows people to live long, healthy lives with HIV. It is why I can be able to sit here and speak with you all. Over 13% of all people living with HIV globally is aged 50 years and above. UNAIDS estimates that this number will triple by 2030. The intention to integrate HIV into primary healthcare and to provide to us services including non-communicable diseases and of mental health services is an acknowledgement of the evolution of the person living with HIV. We are more than HIV in our social lives and certainly in our health needs and ambitions. Last year, GNP Plus and partners held the Living Pre-Conference at the AIDS 2024. 2 groups were visible in this meeting: the older people, the younger people. The message was the same. We would like to get our services from one place. It is increasingly difficult for us to get our services from different health facilities. In that very meeting, we also learned of people who have experiences getting all their services from one clinician. Integration emerged as one of the most important ways for us to access our services. Not because of the funding, but because we need it. Having learned from different partners in this meeting about the realities of the HIV funding landscape and the efficiencies needed for the health sector, we also understood that Integration is essential for us as a pathway for securing our treatment access, but also for securing universal health coverage. GNP Plus was tasked to coordinate us all to define people living with HIV minimum standards of integration of HIV into primary healthcare and universal health coverage by people living with HIV. We hope to release this report in December at ICASA together with you all. To do this well, we have to learn from the lessons of implementation science that has been ongoing for many countries. Many of our people living with HIV networks from Africa region are members of SEQUEN. Many others have engaged with partners like PATH to test and model different options for integrating HIV services and other services needed by people living with HIV. Other regions who do not heavily rely on donor funding have been steps ahead and provide significant lessons for us to all take in right now in the African continent to ensure that integration, planning, implementation, monitoring for better quality services continues to be informed by what is realistic to the communities from where the services are needed. I believe it's possible. Thank you very much.
We thank Florence Anam and the GNP Plus network for the statement, again calling upon the integrated approaches, but of course we are also very much in need of hearing the voices of people with lived experience. We are now moving into the final section, or the final half of our event. We were a bit delayed with the start due to the late arrival of the ministers, so we appeal to all remaining speakers to be very mindful of time, so that we can all move on with our busy day in New York without being too much delayed. So we will move to the second section, which is about making integration work for people. HIV, TB, NCDs, and mental health condition in primary healthcare. There will be 2 panels, and Kathy, you will introduce the first panel, please.
Thank you, Bent. We're very much looking forward to hearing the country cases. So I'm going to introduce the speakers, and then if you could come and take a seat. So Amari Ubuguyu, the Assistant Director of the NCD for NCDs at the Ministry of Health in the United Republic of Tanzania. Welcome. Thank you. I'd like to introduce Sarabjit Chada, who's the Country Director for Find India. Welcome, Sarabjit. Next, I'd like to introduce Suvanand Sahu, who represents the Stop TB Partnership. Thanks, Suvanand. And from my home country, it's a pleasure to introduce Jeanette Hunter, the Deputy Director for Primary Healthcare, Ministry of Health, South Africa. Wonderful. And I'd now like to call on Fine CEO, Ifedeo Aditiva, to provide some opening remarks. Thank you.
Thank you very much, Kathy. Good morning, everybody, and I'd like to start off by thanking our co-hosts, the WDF, NCD Alliance, UNAIDS, the United for Global Mental Health and Resolve to Save Lives, and of course, governments of Tanzania and Denmark. In the words of Tina Turner, you're simply the best. Thank you very much for making this happen. A lot has been said today, and actually I've been quite delighted to hear various speakers echo already the message or the framing that I'm meant to provide for this particular panel. We all agreed that there's a need for integration. And the additional part of that sermon to preach to you, if I may, is that diagnostics enables the convergence that we require at that level. To have one entry point at PHC that links HIV, TB, NCDs, mental health, and all of the other concerns that we have, diagnostics is the enabler of that convergence. And for example, we already have policies about bidirectional screening for TB and diabetes. We have policies already for integration of HIV care too, along with managing hypertension and diabetes. So we've already started, and I think what we need to do to achieve scale at the population level for the most impact is to ensure that we've got an entry point to care that is diagnostics-led. At a time in public health and curative health, there's a lot of emphasis on presumptive treatment or empirical treatments as a means to urgently deliver to populations the care that they need. We need to move away from that now to be more deliberate and more purposeful in ensuring that diagnostics provide the entry to care. And why do we need to do this? In an era where we're looking at funding and looking at the debates about where our precious dollars should go, there's a need, obviously, for prevention, and diagnostics allow us to achieve early detection and, of course, treatment initiation to reduce morbidity and suffering. Beyond identifying conditions, we do need diagnostics even to monitor care and to ensure that management or clinical management is safe. Indeed, as we noticed during COVID with population-level testing, the availability of diagnostics for both identification or for monitoring empowers people to contribute a lot more to their own self-management. What do we need to do? I don't think there's a lot of conversation, we've seen examples. I believe we already have what we need to get started. We have the frameworks, WHO frameworks. Again, as I referred to earlier, TB and diabetics collaborative framework was first of all muted more than a decade ago and has been updated. We've got the 2025 WHO guidance for HIV service delivery, which again reinforces the notion that we need to integrate HIV care along with care for diabetes and hypertension within those services, and in a way that allows us to align both clients
just one minute,
and provider preferences. So we do also have the lessons from the recent health emergencies, COVID, Mpox to Ebola, that highlight that diagnostics are central to resilience. What I believe, and as you will hear from this panel and the examples, is that the same centrality must apply in everyday healthcare for the common conditions that we're concerned about. And we will hear concrete examples from Tanzania, India, and South Africa that demonstrate that integration is not just theoretical, but actually happening in life. So I'll close by calling for some actions. It is important to invest in diagnostics as shared infrastructure. So it's not just the workforce, it's not just the medicines, it's that diagnostics, preferably at point of care and multiplexed, is shared infrastructure. We need to embed diagnostics into the UHC benefit packages and frameworks. And we need to ensure diagnostics reach communities so that access is not just about technology, but about equity, about dignity and trust. Finally, we must consider diagnostics as the connective tissue of integrated health systems from the first tests or diagnosis to lifelong self-management. If we want equity and people-centered primary health care, we must make them accessible to everyone, everywhere, and when they need them. Thank you very much.
Thank you very much, Dr. Tafayo. Very strong statements, and we will ask you to take your seat, please, and we'll move straight to the first country case, which is from the United Republic of Tanzania. Dr. Buguyu, please, the word is yours.
Okay, good morning. Yeah, I'll take you through the slides. And again, integration, it is at the heart of Tanzania. Our nation is United Republic, so it is integration of two sovereign states, Tanganyika and Zanzibar. From the inception of these two countries, when we were independent, we integrated our issues because we know the value of working together. And again, most of the things that we are talking about today about PHC were done back in the 60s because immediately after independence, we had very few people who were educated. And we started with the universal primary education, whereby somebody from standard 7 we are capacitated to train others. So from independence, we started with UHC, including health and education as a universal primary health education, universal healthcare services back in 60s. And because of bigger resources that we had to leverage. So it is not a new thing, and we have to move on with that again. Just a snapshot of the country profile at the moment. We have higher prevalence of NCD, and if you look at the chart there, you see that most of the mortality occur in under 5s. But again, for the NCD and the injuries, mortality occurs beyond 20 years of age, and it is in significant numbers because the infectious conditions after that goes down. But luckily, we had a lot of investment at the moment. In our budget, we invested almost fivefold on NCD as compared to 5 years ago, and simply because we are able to show the numbers. With the integration in Tanzania, we remind ourselves, let us go back to the basics, and WHO has 6 building blocks. And then we can't go with integration without going back to those 6 building blocks. I've highlighted 2, and because of for the sake of time, I'll just concentrate on the 2 areas, leadership and governance and service delivery. But in a nutshell, we are working with the workforce, thanks to WDF and other colleagues who are supporting us on human resource, our healthcare information system, and again, financing and medical supplies and technologies. We have a medical store department which coordinates all the supplies and commodity within the country. Very few medications which come vertically, and for most of the demonstration project, but otherwise they are all incorporated within the medical store department. So I'll concentrate on these 2 areas. One, on the leadership. We'll never do integration if the leaders are not with us. So number 1 is leadership and governance. In Tanzania, we are using 3 key platforms for the integration. One is SWAP mechanism, a sector-wide approach, whereby priorities within the sectors are set and resource mobilization are done through SWAP mechanism. And then we have NCD multi-sectoral strategic plan that is a very technical, interpreting the priorities and plan of action. And then we have health in all policy, mainly just understanding what are the policy platform, what are the policy priority, and call upon all sectors to make sure that we align most of the things. But we have other platforms like a mental health and psychosocial support platform. We have One Health platform. We have nutrition multi-sectoral action plan platform. We have adolescent, so many other platforms which contributed to NCD multi-sectoral strategic plan. Again, on the service delivery, it is quite evident that once you do some integration, especially at PSC, you lower costs significantly, both opportunity and operational costs. It is very easy and cheap when you treat somebody at PSC. Consultation fees goes down, human resource for health required low and of little skills. They don't take longer to train them. And people just walk in within the Pema Healthcare facility. It is very difficult to navigate within tertiary facilities because of the huge size and bureaucracy within those facilities. And to many, they don't go to hospital, and rather they go to buy medication at just a pharmacist because it is difficult to navigate through. So if you take NCDs down to PHC, we will guarantee adherence to care and early detection as well. We have, at the moment, integration of HIV and NCDs with support of Global Fund and PEPFAR, but as well as perinatal mental health initiative. In the community, again, we have a lot of investment, and most of the things at the community are started with NCD. We have a lot of marathon, and all of commemoration, NCDs are also integrated. And we have universal system for data capturing. But let me finish with this one. It is very difficult to integrate these services if we don't integrate the funding mechanism. Most of us are driven by resources. So it will be very difficult if donor community are fragmented. HIV, they are where they are because of a global fund and PEFA. This is a unified funding scheme. So to have integrated services at the community, we also need to have a unified funding scheme. Thank you.
Thank you very much, Dr. Buguye. We discussed in the organizing group whether we should have a call to action or something like that. We had a statement from you now, joint financing mechanism, single systems of health system investment. We will now move to the second speaker of the panel. Please, Kathy.
It's a pleasure to introduce Sarabjit Chadha, who represents FIND. Looking forward to hearing about the work that you've been doing. Thanks.
Thank you. So I'll just give a little background. You know, we've all been talking about various models, and this is actually an implementation, a demonstration model that we implemented in India. And considering, you know, that India carries the highest TB burden, almost 28% of the global incidence, and is also now the NCD capital with the increasing prevalence of diabetes, with over 95 million diabetics and 260 million hypertensive cases. And the thought was, you know, how we can use the TB program, which is much more advanced, you know, than the NCD program, and leverage this to actually provide integrated care to patients, you know, who are at high risk, the vulnerable and marginalized communities. So this project was implemented by FIND India, along with the National TB Program, the Ministry of Health, the NCD program, Myrada, a local NGO, and generously supported by the Stop TB Partnership under TB Reach Wave 10. And the basis was to demonstrate an integrated community-based service delivery model, which actually delivers services for TB, for non-communicable diseases, focusing on diabetes and hypertension, and non-TB lung disease, more like chronic respiratory diseases like COPD and asthma, through women-led self-help groups. You know, I think I've highlighted a few points here that, you know, how we were ensuring gender equity and community ownership through this project. We actually targeted 2 million vulnerable population across 2 districts in a southern state in India called Karnataka. And just to make sure that, you know, this intervention was actually working, we also identified a control population which had similar socio-demographic and TB-NCD burdens within the same state. So this is just, you know, some pictures, and this explains how we worked about it. So we had, you know, awareness generation and capacity building, which laid the foundation for this project. We had the women self-help group volunteers, you know, who visited the households. They did TB symptom screening. We used innovative tools like AI-enabled X-ray screening. Patients did not have to undergo some inconvenience to deposit their samples. They were collected at home, and then NAT testing was done, and they were linked with treatment. Simultaneously, you know, the household members were also tested for TB infection using one of the latest WHO-recommended TB skin tests called CyTB. And those, you know, who were found positive and did not have TB were started on TPT as well. For NCDs, we equipped these women self-help volunteers with glucometer. They tested all the eligible household members for sugar, and using a BP instrument, tested them for hypertension as well. And if they found abnormal readings, they were linked with further care. Now, these are some of the numbers, you know, which speak for themselves. And if you look at it, you know, we had about 2 million people across 500 villages, you know, and these were all high-risk groups. And we identified and tested 43,700 presumptive TB cases, which resulted in diagnosis of nearly 1,600 TB cases. We also did 7,100, you know, TB infection screenings. And out of this, you know, we found over 1,300 eligible patients who were started on TB preventive treatment. We also, you know, operationalized AI-enabled chest X-ray screening, and we did over 8,000 such X-rays with a 15% positive screened, those who were then subjected to further testing. I would like to bring the attention of the House to the NCD group. You can see the number of TB patients we could diagnose, which was about 1,600. But look at the number of patients, who were found to be at risk for diabetes. These were like 42,000. Hypertension, nearly 50,000. And out of these, when we linked them with care, we had...
One more minute, please.
We had over 2,000 diabetic cases and over 3,000 hypertensive cases who were diagnosed and linked with care. This is just to show the impact. And if we looked at the intervention and the control population, while TB notification increased significantly, by 5%, in the control population, the TB notifications actually got dropped. What was ironical was that while we diagnosed a lot of diabetes and hypertensive cases, we could not assess the increase because there was no baseline data available, which shows that recording and reporting was not happening. Key lessons from this project: community trust is critical, and that actually led to screening of so many patients, of so many households in the community. Integrated service delivery works. I don't need to enhance this. You can see that from the numbers. Innovation can happen. We used AI-enabled X-rays. We used latest skin TB tests, and these all worked. And partnerships drive sustainability, which included both government ownership and community ownership. There were challenges. Nothing was like seamless. Vertical programs working in silos, we had to create those linkages between the TB and the NCD programs. Diagnostic access issues were there. We had sample transportation, like I said, and patients need not go to the facilities to deposit their samples. Data collection challenges, again, we used AI to convert handwritten text into digital documents. And there was limited adherence support under NCDs to follow up on the patients, unlike the TB program. So I'll end, with acknowledgements to the National TB Program, the National Control Disease Program, Non-Communicable Disease Program, the Stop TB Partnership, MyRADA, and all the beneficiaries, the SAG volunteers and project team. Thank you.
Thank you, Sarabjit. And as you mentioned, this project was in collaboration with Stop TB Partnership. So we'd like to invite Suvanan Sahu to share some reflections. Thank you.
Thank you. Good morning and greetings from the Stop TB Partnership. You heard Sarabjit about the work done in India. Let me just give you a bit of a global perspective on this. So at Stop TB Partnership, not now, but a few years ago, we have been convinced that the only way to scale up TB response is to go the integrated way. And that is the reason we have this TB Reach initiative, which is an innovation platform. I think many people here in the room have also experience of working with TB Reach. And in the last two waves of TB Reach, wave 10 and wave 11, we focused it on integrated care delivery. And as a result of that, we have 46 projects in 21 countries with a total amount, about $26 million working on how these kind of integrated TB along with other non-communicable disease services can be delivered. And very good learning there. I will come to a few learnings there, but just to highlight a few things for this audience. Why it is important for TB and NCD to work together. If you look at the risk factors for TB and NCD, if you look at some of the drivers of NCD and TB, they are similar, right? You have malnutrition, you have air pollution, you have diabetes. Many things are similar. We have comorbidity as Sarabjit presented. 1 in 4 TB, in some places 1 in 3 TB also has diabetes. If you have diabetes, it increases your risk 3 times, triples for TB. If you look at diagnosis, TB has a big diagnostic gap, and so also the NCD. We have huge numbers of people, billions of people who do not know their status. So there is a possibility to work together. Also, if you look at the care, the treatment, TB is long-term. You have to engage from the health system. and also for NCD, you need a long-term care there. Now, the lessons that we learned in TB Teach, a lot of people were diagnosed with TB and TB infection, as you saw from Sarabjit in one project. From all the projects, we have something like 250,000 people diagnosed with TB or TB infection and linked to care. When we looked at the NCD conditions that were diagnosed, we had to struggle. And one of the lessons is, in many high TB burden countries, the NCD services are not available. So as a result, when you link them to care, the follow-up is very difficult. Treatment sometimes is expensive because people have to choose private care providers because of absence of public sector there. So what we want is the TB community is eager to collaborate. There are some people in the room from the TB community. We appeal to the NCD stakeholders to ensure that wherever you have TB services there, let's collaborate. Let's bring in the resources, the expertise all together. We need to keep our ambitions high because 2 billion people today, 2 billion, not million, are infected with TB, latently infected. We just heard hypertension, 4 billion plus. So we are talking here about screening, testing billions of people. And we can do that only if we combine all our resources, our expertise, and we have to keep our ambition high. Thank you.
Thank you very much, Sivanand. Some powerful reflections. I want to remind the audience as well, in the global repository on the QR code, you will see there's a report as well that goes into more detail of the project in India. I'd now like to introduce Jeanette Hunter, the Deputy Director of Primary Healthcare from the Ministry of Health, South Africa, to present to us. Thank you, Jeanette.
Thank you, Kathy. Good morning, everyone. I'm very pleased to share with you South Africa's experience. I hope I get the pointer right. Yes. So I want to talk about systems improvement. And the systems improvement for person-centered care, and we choose that word person deliberately as opposed to people, because a person becomes nameless in a group of people. But with focus not just on the patients, but also our staff. We want to create the environment in which staff are motivated and comfortable to provide good services. So we started our drive towards person-centered care in 2013. And we looked at the infrastructure required to provide good services. And here we're talking about our physical brick and mortar structures, other infrastructure like information systems. We looked at the legislation, policies, strategies and protocols that we need to provide good services. And then, of course, what are we doing about the clinical care in terms of our burden of disease? So who are we when we talk about the health system of South Africa? We organized our services across our 9 provinces into 52 districts. And those 52 districts were broken down further into more than 200 sub-districts so that you take the management of services closer to the people that you want to service. So you would see the darker blue ellipse in the middle represents a primary healthcare facility with all the support services around it that it needs: school health services, community health services, environmental health services, social work services, psychology and psychiatric services. And you need that integration, you need that chain linking all those services for the sake of that person that Ms. Carol Nawina has referred to earlier this morning when she addressed us. And then outside of the district health system, you need the referral link to a higher level of services for more sophisticated diagnostics and care. So us being who we are in terms of providing our services according to the district health system, what do we stand for? We recognize that as a collective, as the people who make up the national health system, private and public sector, we need to agree what we stand for. You ask someone, what do you stand for? I stand for quality services, but what does it mean? So we stand for universal health coverage. That is why the blue triangle towards your right. And we've organized our services from community-based into physical facilities, supported by emergency medical services, supported by diagnostic services, and supported by all the different support services to be able to work towards universal health coverage. Why? Why are we doing this? You have a country and health systems context. And within that country and health systems context, you have to deal with the patient and community characteristics. And here I'm talking about the social and economic determinants of health. That are, when a big majority of the population are poor, like in South Africa, you struggle with negative social determinants of health. And then I've spoken about our health facility characteristics. So I'm going to move to the block that says outcomes, because we all want better health outcomes in terms of our total burden of disease. The key communicable diseases, but also the key non-communicable diseases. Because again, Carol reminded us about one person having communicable diseases like TB or HIV, and then also non-communicable diseases. You want patients to be satisfied with the care that you give them, and you also want them to have a confidence in the health system so that they can come for early detection, so that they stay on treatment. So I moved back to the middle block where let me see, how do I go back? Oh, there we are. Where you say, how do you influence the patient's experience of care so that they can come back and remain sustained, and it's covered there. I won't go through it for the sake of time. So again, I said this is what we work towards. So in 2013, that's a newspaper article from 2013, highlighting that in a certain community we were servicing people out of a tent, and not even a tent that was well intact. And even if we were not servicing people out of tents, even some of our physical facilities were very bad in terms of infrastructure. That very clinic was moved. There's an aerial photo. I have hundreds of pictures showing it inside, but also just to show you the toilet on the left at the bottom that those people and the staff had to use. And so we moved to facilities having toilets like the one on the right. Because we can't talk about integrated services. You can't talk about better outcomes for diabetes, for cancer, if the infrastructure that you're trying to deliver services from totally demoralizes the people servicing the patients, and patients are also demoralized to visit those facilities of yours. Some of the key legislation pieces that we use to harness the team into one team working towards shared outputs. Then clinical care, most importantly, the fact that we built an infrastructure and policy and protocol platform doesn't mean we were neglecting clinical care. Most importantly with clinical care, there was a framework from the WHO that spoke about integrated non-communicable diseases. In 2013, we decided we're going to talk about integrated clinical services management, so that you recognize you need to integrate our two most important communicable diseases, being HIV and TB, together with our 5 important communicable diseases. And we looked at training programs to orient people towards this integrated way of caring for people. We also reorganized our services within our health facilities so that people are helped in one consulting room for everything that's wrong with them, and they also get their medication out of that same consulting room. And the title of this workshop is Equity and Integration. So we don't just build beautiful clinics in our big cities like Johannesburg and Cape Town. That clinic I showed you the aerial view of was built for this rural community. And as you can see, it's Lusikisiki Village Clinic. We do have challenges. We still have incomplete multidisciplinary teams looking after our patients in the districts. A lack of an electronic health record is a big stumbling block in terms of looking at your patient longitudinally to determine whether your patient adheres to treatment, the treatment works for the patient, or if there's any other change interventions that you need to do. And the way for us the way forward, our next steps, is to cost what we call our care coordination framework for integrated patient care, so that we can incrementally improve in terms of the challenges that we still have. Thank you again.
Thank you very much, Jeanette. And thank you to all of our panelists for the very real experiences that you've shared from all of the countries around that integration is possible, but of course there are challenges that we need to address as well. So thank you, panelists. You may take your seats. Handing over to Bent to introduce the final panel for today.
Yes, it is the final panel. We know we are a little bit delayed. We might ask you to stay maybe 10 minutes more. All have a busy day, but we will go into the final part now. So please, if you could stay another 10 minutes over time, we would appreciate it. The third and final panel is again about making integration work for people. And we take stock of where we've come since the 2018 third high-level meeting and tomorrow the fourth high-level. If there's one area where we've seen major progress, I would say it is in the area of mental health. And we reached out to James Sale and the group, inviting them to be part of our event today, and we are very pleased to have you here. James Sale and United for Global Mental Health, please, introduction remarks from you. Thank you.
Thanks very much, Ben. This is the express version because we are short for time. So bear with me and buckle up. I think we all know, and it's been spoken about today, there remains a huge lack of attention and action when it comes to all of the issues that we represent here in this room. But that is particularly acute when it comes to mental health. And this is despite 75 or up to 75% of primary healthcare visits relating to mental health. We don't have current systems that provide accessible, person-centered, high-quality, rights-based services to people with multiple chronic conditions, including mental health and NCDs. It's critical to understand that in most countries, mental health is heavily focused on providing services in institutions, where involuntary admissions, arbitrary detentions, coercive practices, inhumane treatment, and other forms of human rights abuses are common. We just looked at, this year, we looked at how many people are actually in institutions for mental health around the world. We released a report last week. 8.4 million people a year are admitted to mental health facilities. That's nearly the same as the total global prison population. I honestly believe that the admission of people who are just unwell to mental health facilities, often against their will, often being shackled, often being chemically restrained, I've seen it, is the greatest scandal in global mental health we don't talk about. But moving on to integration, we modeled the data for HIV and TB and mental health integration a couple of years ago. And if we had a modest package of mental health services integrated into HIV and TB services worldwide, then nearly 1 million HIV infections and 14 million TB cases could have been avoided in the 8 years leading up to 2030. But we have seen a reaction. The Global Fund has integrated mental health into its strategy, and the latest Global Fund grant cycle, GC7, has allocated $200 million to mental health and substance use, with a huge demand from governments for mental health integration. 54 countries meaningfully including mental health in their applications. Development partners, do not tell me there is not a demand for investment in mental health integration into primary health care. For the first time, heads of state are coming together to discuss NCDs and mental health at a high-level meeting. And they are making progressive policy commitments in the political declaration, which the mental health community has called for. And I understand where there is disappointment in other areas, but as a mental health community, there is progress, and we can see progressive text. And this includes providing better mental health support for young people, reducing suicide rates, modernising mental health systems away from those institutions, as well as integrating mental and physical health services. So we do celebrate the political declaration, we celebrate a newfound ambition for mental health, and we celebrate the voices of experts that have been listened to. But that's just the start. From here on, we must hold governments to account for timely and full implementation with multi-stakeholder mobilisation and collaboration so that commitments translate into actions that save lives. Thank you very much.
Thank you very much, James Sale, United for Global Mental Health. Could we please have the final panelists to take their seats? Maria O'Brien, please take your seat. Hibot Solomon, Federal Ministry of Health of Ethiopia, please take the seat in the panel, and also Gladwell Gathecha from the Ministry of Health of Kenya. This will be the final panel, and we ask kindly the speakers to be very mindful of time. We are a bit short on time, and we would like to give the word to a person with lived experience, Maria O'Brien from Trinidad and Tobago. Please, the word is yours.
Good morning. Good morning, honorable healers, health leaders, policymakers, and advocates, and a special solidarity greeting to my fellow persons with lived experience of NCDs and mental health in the room. My name is Maria O'Brien. I'm here representing Mindwise Project, and especially Caribbean and SIDS, NCDs, and mental health. I am very happy to see at this time, at this important event, that SIDS has found a special place to be given a voice, as we are the world's most vulnerable in our current climate crisis and emergency situation. I have been working as part of teams organized by the Global Mental Health Action Network, United for Global Mental Health, NCD Alliance, HCC, GMHAN, and the WHO Meaningful Engagement Committee. We are here to raise the voice of lived experience. I myself, I am a survivor of breast cancer, another suicide, and my own ideation and crisis, PTSD, domestic violence, and child abuse. I also have experience on both sides of service delivery, as a patient and as a national partner in MHPSS service delivery. So, diving into my very brief statement, when you are a patient, it's not just your body or your mind that is being treated. It's all of you, one whole person. The fatigue that NCD patients, such as myself, experience hopping between clinics and waiting rooms, along with the side effects of our treatments, some of which I'm experiencing right now, creates a breeding ground for mental health conditions and risks. The stress of not failing to keep our eyes on the ball is massive. Our mental health risk, as many of you know, increases our NCD recurrence risk. So the stress of being on top of it ourselves versus it being part on the agenda of our service providers is very stressful and overwhelming at times. Knowing that the dangers of either not being managed effectively or consistently can result in further disaster. Poor mental health can also lead to bad physical health and hygiene. Poor physical health and choices can lead to mental health crisis and increased risk of self-harm, addiction, and suicide. Are you listening? Some doctors, and I acknowledge this from working with doctors, are also traumatized. So they don't always hear our cries for help, our crisis. Sometimes it is stigma that prevents you from, or them, from asking important questions such as, are you thinking about self-harm or suicide? For those of us who work in suicide prevention, we know that this is a question that can save someone's life. My experience feeling suicidal in a cancer clinic and while being physically assessed for my monthly appointment, advising them of my suicidal ideation, depression, and risk, and no clear pathway to mental health support was presented to me. Of course, they did not know at the time that I was a mental health partner. I do think that it is important for us to take these important steps that can help integrate mental health into NCD care in a realistic time frame. We know that it can't all happen all at once. Simple things that can be done are adding questions about mental health or NCDs or personal life experiences to follow-up forms that doctors are using or even frontline service providers are using when they're evaluating patients and checking up on them. This could dramatically improve patient oversight and connecting the dots in treatment plans between what's happening in their real lives and what you are seeing in your offices. Having effective training and health promotion materials for service providers who may not have the time because they are also overwhelmed with everything and the burden that they are dealing with can help them provide support without having to go through massive training or knowledge sharing for them to understand how to present it. So having those materials on hand can really help them help patients. And finally, the meaningful engagements of persons with lived experience on every level of policymaking, treatment plans, talking to patients about their personal lives, what's happening. These are really important parts of improving and integrating NCDs and mental health. And of course, reality into our treatment plans. We, as persons with lived experience, are the voice of the vulnerable and the voiceless. The few of us that are here and have been honored to be part of these proceedings are really trying to speak up for the hundreds of thousands and millions of patients who could not be here this week. So we thank you for having us as part of this event. We thank our amazing hosts and mentors who have been guiding us all along, but we really do urge you to include your patients in your planning, create channels for you to hear their voices, meaningful, structural channels. And we, as your partners and allies, look forward to working with you and discussing any questions you might have on how this can be done. So thank you very much.
A round of applause to Maria O'Brien for a very powerful statement. Thank you so much, Maria. We are almost reaching the end of our event. We are in the final panel. We have invited 2 representatives from Kenya, respectively Ethiopia, and I have just agreed with Dr. Gladwell and Dr. Hebert that you will both make a brief remark about integration in your national contexts, please, and then you will make a reflection on the future of integration in your contexts. So a short statement from you, Dr. Hebert, please. Federal Ministry of Health of Ethiopia. Thank you.
Thanks so much. Good afternoon, all. This is a great privilege and it's opportunity for me. I will be very, very brief. Yeah, Ethiopia is, as a country, as fan of integration, and also after the global direction from the primary health care, access to everyone, no one health left behind, so on. This is a great move for the country to take and to act, so that nationally the Ministry of Health embark on this all very important key public health acts. So, you know, primary health care is a center for health delivery, particularly country like Ethiopia with a limited resource is very important platform to go for and act for integration. So that starting from the sectoral strategic plan, there is a bold statement that to use and also bringing efficiency by considering different health programs like non-communicable disease, different infectious programs like TB, other chronic illness, cancer, and so on. Particularly mental health is cross-cutting element we have to entertain. So we are bridging non-communicable mental health issue within the maternal health platform, as well as different disease integration are our experience. Just to give you, recently WHO designing a people-centered eye care program, and we are the one also moving and working and becoming a showcase as a country to go for that, and also bringing the care down to the community level with this very important instrument. Similarly for malaria, TB, some of the speakers previously already entertained that using innovative approach even to further intensify the integration that will really help task sharing and task shifting points there, and we are really enjoying with that, and also try to serve a better way to our community. Generally, it's already have a great buy-in, and we will strive further for a better service, and thank you so much for the opportunity.
And the future, sorry, Dr. Hebert, the future for integration, the future of primary care, people-centered care in Ethiopia? What do you see in the future?
The future is more than bright because we are taking the health sector strategic plan direction. For all disease program, we are entertaining, bringing a better service. In this case, sometimes health facility will not be a better position for ideal service for the patient. I can give you an example. Some of the intervention we are using civic society, local civic society, different stakeholders like association, like patient group, and so on. So there are many areas we are entertaining and looking a better outcome out of that platform. Thank you.
Thank you, Dr. Hebert. A round of applause to Dr. Hebert, Federal Ministry of Health of Ethiopia. The final speaker of our event in this panel, Dr. Gladwell, Acting Head of the Division of NCDs at the Ministry of Health of Kenya. Dr. Gladwell, how are we progressing with integrated care, primary health care level in Kenya, and how do you see the future? A final statement from you, please.
Okay, thank you, Bent, and good morning to you all. So I'll try and give a snapshot of what you've done in Kenya. as far as integrating people-centered primary health care models. So first of all, our NCD burden is around 38%. And what has really given us the push is that we have a solid environmental framework in form of, first of all, legislatives and policy framework. So we have a Primary Health Act that was enacted in 2023. And what this does is lay a foundation for implementing integrated services at primary healthcare level. And then most importantly, it also stipulates that services are offered for free at primary healthcare level for anyone who's registered and just is able to get these services. So that already removes the financial barriers that are associated with accessing services. And then number two, we have not done it alone as a government. We've done it together with partners. And the various pilots that we've done before with their partners has enabled us to see what works and what does not work, improving on the next rollout we've done as a government. And then I was also asked to speak about how we've managed to converge the various international partners towards working in the government directive. And first of all, we do have a formal coordination mechanism. Like, for example, we have a technical working group for integration of diabetes, NCDs, as a whole, and HIV, and where this is a formal engagement where partners are really asked to say what they've been doing, and also it's a decision-making body that plans ahead. We also have a technical working group for diabetes and also TB. Again, they do the same planning jointly so that every partner is able to see what is required and the gaps required of them. Secondly, we have formal government directives in form of our priorities that are laid down in our NCD strategic plan. And when partners approach us, we direct them to what is the priority, either as a 5-year plan or an annual plan. But this has also not been very easy because Kenya, we have a decentralized health system. We have 47 health counties that are supposed to be given direction at national level, but at the same time are also autonomous. So when we do direct partners to the lower levels, they usually have different variations of how things need to be done, and that has been a bit of pain in the counties that are not very cooperative. But all in all, we have most of the decentralized units being very cooperative. And for us, another success point is that we have protocols that we developed and launched this year that have integrated NCDs, the common NCDs, that's diabetes, hypertension, cervical cancer screening, breast cancer screening, and mental health. So this is a very simplified pocket-size protocol, and it has proven to be very popular among primary healthcare workers. So no need to have different guidelines for the disease specific, but we have just that one overall simplified protocol where they can make reference to. And for the a bit more unique situations, like for example, we have a protocol for diabetes, TB bidirectional screening. All in all, what I can say has been major levers for these success stories is, first of all, involvement of persons with lived experience. And it has come to a point where we really are not waiting to call them. They are demanding of us, and they are demanding that they want these integrated services, and they are saying, what can we do? Among the HIV space, they are living longer, but they have increased incidences of NCDs, and they are saying, let's come. They are coming to us at the Ministry of Health and saying, what can we do to work together? So that involvement has really helped us entrench a lot of these interventions of integration jointly. Another thing is also empowering our NCD leads at sub-county, at county levels. So there is me who heads the NCD division at national level, but I have 47 other leads at county level who equally need to be empowered, and we are empowering them by providing them with the information. Also, just for example, through the World Diabetes Foundation, we have established a multi-sectoral coordination committee in each of the 47 counties, and they are able to bring in their counterparts from HIV and also from out of government. My parting shot, Bent. So I think a lot of
Well, let's have a last
Yes.
question to you,
So
Dr. The
yes.
future of integrated care. I think it looks bright, but please
Yes.
let us have a final remark from you.
So a lot of progress will be encountered when we incorporate the integration agenda to the broader health agenda. So that will be ensure that all our interventions are scaled up much faster and there is more ownership at government level. Thank you.
Thank you very much. A round of applause to this final panel. Dr. Gladwell, Ms. Maria O'Brien, and Dr. Hebert, please, thank you again, and please take your seats. We are at the end of the event. We have been through a series of statements, interventions, and sharing of lessons learned. We heard from the government of Denmark, Minister of Interior of Health, and from the Minister of Labour, Economy and Investment of the United Republic of Tanzania, a clear commitment to the integrated primary health care agenda. We heard from Leanne Riley of the World Health Organization how strong the integrated care agenda has become, the technical products and normative work to member states. We heard from the coalition of primary health care supporting member states, represented here by Kazakhstan, with, I believe, almost 20 member states and hopefully more to come. We heard from France, and we heard from the Africa Center of Disease Control, which is the health agency of the African Union. We also heard from Resolve to Save Lives. We heard from FIND, and we heard from United for Global Mental Health, how global agencies are investing and supporting progress on these respective areas with the intention of convergence into united, integrated primary care with people-centered focus. Most of all, we heard from a series of countries. We heard from Tanzania, we heard from India, South Africa, Kenya, and Ethiopia, how in actually much progress is already happening. Sometimes when we meet here in New York, we endorse declarations and we host side events of things we hope to do more, but sometimes it's already happening faster than we know. So thank you to all the government and country representatives who were here. Of course, we heard from Carol from Zambia, from Florence in Kenya, and from you, Maria, from Trinidad and Tobago. There you are. The voice of the person with lived experience. One progress we've seen since 2018 is the integration, inclusion of the voices of the people with lived experience, and that is something we should continue doing. It's impossible to summarize an agenda like this, and it's also impossible to go into depth with the agenda like this in 2 hours. But the intention of this event was to give a snapshot, an introduction, and a call to action to advance this agenda. Tomorrow, the political declaration will be endorsed, and there's a big chapter, much bigger than the previous declaration, on primary care. So this is the momentum to take onwards. But we are not done with the event yet, because we have invited the NCD Alliance CEO, Katie Dane, to come and give closing remarks. And Katie, I would like to invite you to the podium to round off our event, and the word is yours.
Thanks, Ben. I think you just closed the event for me, really. I know we're all about to get our roller skates on to run to the next one. But let me thank our fellow co-hosts, thanks to our speakers, to our moderators who've done a fantastic job, and for all of you for starting your special Wednesday with us at this event on integration. For me, I think this event has been a real breath of fresh air. I mean, I've been in the NCD space for a long time, and I think that we all dreamt of this kind of event happening in 2011 at that first high-level meeting. So it's fantastic to see so many parts of the global health agenda coming together
and really reinforcing that point about integrated, people-centred primary healthcare being the way forward. For us at the NCD Alliance, this agenda has obviously been very central to our campaign priorities for the high-level meeting tomorrow, both in terms of accelerating implementation of primary healthcare and NCDs, but as well as breaking down the silos across global health to work together. And as I say, really encouraging to hear so much leadership and commitment on this agenda today from the global level as well as the country level. I think also it's really important just to kind of reinforce the point of how critical it is to safeguard the wins and gains that we've made during this era that we find ourselves in. I think as purse strings tighten around health, there is a real risk of reverting back into that vertical mindset. And as I say, I think today has actually proven the exact opposite. Integrated primary healthcare, as we've heard from so many other speakers, is both a smarter no-brainer option from an economic perspective, from a systems perspective in terms of leveraging infrastructure, personnel for multiple diseases rather than one, and most importantly, as we've heard, from a people perspective. And going back to what Carol said there right at the beginning, this is about survival, absolutely. Our attention now, after this week and the high-level meeting tomorrow, has to be on three things. Number one, advocacy. Number two, implementation. And number three, accountability. As Bent just said, the new declaration provides us with another entry point and a tool for advocacy, and a huge amount of opportunities in the years to come to keep that momentum up. The HIV/AIDS high-level meeting happening next year here in New York, the Global Coalition on Primary Healthcare that we heard from Kazakhstan earlier, and the high-level meeting on universal health coverage just a couple of years down the line. I'm sure we're all a little bit drained by high-level meetings right now, but these are important global milestones that we can all work together towards. So now it's all up to us in this room to translate the energy and advocacy of this week into lasting change on the ground, to roll up our sleeves, to move from words to action, and from silos to synergies. And I think, as Bent said earlier, the future has to be integration. So thank you again for joining us. Wish everyone a special Wednesday and a supercharged Thursday as we go into our high-level meeting. So thank you again.
Thank you, Katie. Thank you so much, Katie. And we are at the end of the event, and we thank you for staying on, and we wish you a fruitful rest of the day in New York, and of course, we will be together tomorrow for the high-level meeting on NCDs. Thank you very much. Have a rest of the day.